Okay, so I think we'll go ahead and get started. So good afternoon, everyone, and welcome to the first CanHeme webinar of 2023. It's my great pleasure to introduce our speaker today, Dr. Greg Guilcher, who will be speaking today on the topic of allogeneic stem cell transplant for hemoglobinopathies. As a bit of a bio, so Dr. Greg Guilcher is a pediatric hematopoietic stem cell physician in Calgary, Canada. He's the medical lead for pediatric HCT and the program director for the Childhood Cancer and Blood Disorders Research Program at the Alberta Children's Hospital Research Institute, based at the University of Calgary. He has held several leadership roles within the Sickle Cell Transplant Advocacy and Research Alliance, called STAR, with an interest in low toxicity transplant approaches, as well as late effects and a broader understanding of outcomes of HCT. Globally, he collaborates with colleagues in Uganda for faculty, resident, and nursing education, and hopes to facilitate HCT program development in sub-Saharan Africa within the Worldwide SCD Coalition. Please join me in welcoming Greg Guilcher. And thank you, Greg. The floor is yours.
Great. Thank you so much for the invitation to speak and for all of you for joining today. And please tell me if you can't hear me, I can adjust my microphone. I'm going to be speaking, as Sarabi mentioned, on allogeneic transplantation for hemoglobinopathies. Because curative therapies of various forms interface, I'll be briefly touching upon gene therapy, although that won't be the focus of my talk, and I won't profess to be an expert in that area. Let's make sure I can advance here. There we go. My two disclosures are that I am involved with a couple of research projects that receive funding from pharma, although I receive no direct remuneration. So our goals today are to discuss why would transplant be considered for transfusion-dependent thalassemia, and typically I'm speaking of a beta thalassemia genotype here, or sickle cell disease. And there are both historic and new approaches to transplantation or allogeneic transplantation for these conditions. And throughout the talk, wanting to identify opportunities to improve outcomes, because access to curative therapy remains a barrier for most patients with these conditions. So how can we go about improving access and making safe cure available to everyone? So this discussion always becomes a real balance of varying competing priorities, values for patients and families, biases or preferences from providers. So we'll try to walk through those and go through the data as to why transplant may or may not be considered for these conditions. And so if I was to simplify some of the considerations for hemoglobinopathies, for transfusion-dependent beta thalassemia, we would typically call this a more predictable phenotype in comparison to sickle cell disease, but characterized by lifelong transfusion, the need for chelation, although newer chelating options are available. And excitingly, some disease-modifying agents are being studied and are hopefully on the horizon. And then gene therapy is commercially available in the United States at a price tag of $2.8 million US for the transduction alone. So a conversation for this group and providers in Canada is who is going to be able to access that therapy. Sickle cell disease has a more variable phenotype, but also a reduced life expectancy, particularly in sub-Saharan Africa, although even in some high-income settings, life expectancy is not increased as much as it should, primarily due to social and socioeconomic variables. Prolonged chronic transfusion is possible, and chelation, therefore, may be necessary. And fortunately, there have been quite a few disease-modifying agents that are either approved or close to approval or subject to intensive study, certainly far more than the single approval of hydroxyurea by the FDA only a few years ago. And gene therapy is likely going to be FDA approved in the coming years, or even year or two. If I was to speak broadly about changes in allogeneic transplantation, I'll speak in more detail about how transplant is performed and some of the nuances. Well, the risks are also evolving for transplant. So for some who may have trained 10, 20, 30 years ago, the way we do transplant has, for some diseases, and notably for hemoglobinopathies, has changed quite a bit. We are using less intensive regimens, although there are advantages and disadvantages to using these variable conditioning approaches, and I'll try to explain in broad strokes what some of these terms mean: myeloablative, non-myeloablative, etc. Targeting some of the most important barriers to proceeding to transplant or complications for those who do undergo transplant, and those important complications being, of course, mortality from the procedure itself, or graft versus host disease. I'll speak a bit about the role of mixed donor chimerism, which in the, if you were to ask me 5 years ago, we would say, mixed donor chimerism is something perhaps we should target because we can get away with less intensive conditioning. But for sickle cell disease in particular, there are new learnings about perhaps placing at least older patients at risk of myeloid malignancy. So we'll speak about that, but there's quite a lot that remains to be learned in that area as well. And very important to patients and families is the potential impact on fertility. So we'll get going with transfusion-dependent thalassemia first. So thalassemia means anemia by the sea, referencing the Mediterranean, which sounds very romantic, but this is, of course, a disease that can impact very significantly the quality of life of patients and their caregivers. When I first pulled this slide years ago for a talk, I didn't realize that my wife and I would end up having gelato at that pink little restaurant there in the middle of the screen. And to tell this group, which really, I would say, needs no introduction to pathophysiology of thalassemia, really we're focusing on the issues of ineffective erythropoiesis and excess iron burden through either transfusions or increased absorption as examples. And these two issues lead to the plethora of complications and the need for various supportive care efforts to keep these patients as well as possible with the best quality of life possible for as long as possible. And so this ineffective hematopoiesis can be suppressed through chronic transfusion, but chronic transfusion is not without its challenges in terms of time, resource, iron burden, alloimmunization as examples. And so as you can see, there are a whole host of complications that can result from ineffective hematopoiesis or the need for chronic transfusion. We'll speak in a few moments about transplantation. It's important to note that quality of life and life expectancy have improved through the years for beta thalassemia or transfusion-dependent thalassemia. So in high-income countries, more than 80% of those with this disease are expected to survive 50 years. And this is a contrast, a sharp contrast to those in lower income settings where very few patients are over 35 years of age. But a recent Italian survey of older patients with thalassemia, and Italy being one of the leading countries in thalassemia care for decades, looked at those adolescents and young adults with this condition using the short form 36 and comparing various health-related quality of life measures to the general population, and found that several indices were quite a bit lower than the general population. And it was striking to me how many hours a month these families engaged in care activities in addition to the time they spent receiving chronic transfusions. And these patients and families reported a high burden of disease. But the trend is improvement in health-related quality of life over time, so I don't want to understate that. This is a study of American, British, and Italian patients, similar findings where individuals and caregivers, individuals with thalassemia major and their caregivers reported a great deal of time spent on disease management and treating symptoms related to fatigue or pain. And I'm sure this audience will be quite familiar with the contrast that we see with new Canadians, particularly from Syria or Afghanistan as examples, who come to Canada without having received the best supportive care since birth, and how complex these patients can be and the impact on their medical and psychological well-being. I won't profess to be an expert on luspatercept, but important to highlight whenever we're talking about curative therapies is how these potential curative options compare to best supportive care. And best supportive care is not static, it's evolving. Fortunately, there are new and more options available for patients and families. So this recombinant fusion protein, whose mechanism of action is not completely understood but can enhance erythroid maturation, will potentially again reposition the role of transplant or gene therapy against best supportive care, depending on the success of ongoing study of this and hopefully other agents. So what about transplantation, and specifically allogeneic transplantation, because gene therapy is also a form of transplant? Well, there's over a 30-year history of curing patients using this approach, with over 3,000 transplants performed internationally. And not unexpectedly, many of the leaders in transplantation are in the Mediterranean region, but also there are some centers of excellence with large numbers of patients in southern India as well as Thailand. And our goal in transplantation is to take blood-forming stem cells from a donor and have them accepted and stably engraft in a recipient so that the ineffective erythropoiesis is corrected, the need for chronic transfusion is no longer there, and iron overload or further ongoing iron overload can be prevented. And ideally, they have successful engraftment, then even phlebotomy or efforts to reduce iron post-transplant can help get rid of some of the excess iron that may have been present going into transplant. And to negate, and this is important to emphasize, the adverse impact of this chronic illness on health-related quality of life. But it's important to keep this in mind because the last thing we want to do is to adversely impact health-related quality of life through the intervention that we're discussing here in allogeneic transplantation. So for those who may be less familiar, many of you may understand what transplant is quite well. Hematopoietic cell transplantation is the procedure of taking blood and blood-forming stem cells from a donor into a recipient, and the donor and recipient can be the same or different people. Now, allogeneic refers to an unaffected donor who does not have beta thalassemia major. Gene therapy is an autologous, at least as at present, is an autologous transplant, if you will, with again the need for chemotherapy in its current form. But here we're going to focus on allogeneic transplantation, and to accept, even with a fully matched donor, to accept these blood stem cells, there has to be some sort of preparatory chemotherapy, immunotherapy, or sometimes radiation therapy, less commonly in thalassemia and sickle cell disease, but some form of conditioning. Otherwise, the person undergoing the transplant will reject these cells outright, even with very close matching. And so to describe this in a figure, the patient here who is undergoing this conditioning, and typically in the midst of this conditioning, so these stem cells can be collected and infused fresh, the donor, after having undergone an extensive donor clearance process, will donate either bone marrow, which is typically the case for non-malignant conditions, or sometimes, depending on the protocol, peripheral blood stem cells. These cells will be processed as required in the cellular therapy lab and then infused intravenously, typically through a central line into the patient, where they then circulate through the bloodstream, identify when they're in the bone marrow, and then start proliferating in the bone marrow niche. And you'll hear through this talk and in other presentations terms which describe the intensity of the transplant. And typically, and this remains the case for most transplants for hemoglobinopathy, what is most commonly used is a myeloablative transplant, and certainly for thalassemia, where doses of typically chemotherapy, sometimes radiation, but chemotherapy for the most part for hemoglobinopathies is given at a dose that one would not expect bone marrow recovery, or at least if it was not irreversible, a prolonged period of aplasia before there was production of healthy blood cells again, if stem cell rescue was not provided. On the other end of this spectrum is non-myeloablative, which is the minimum amount of chemotherapy, immunotherapy, or radiation needed to get donor cells to successfully engraft, and then reduced intensity conditioning is somewhere in between. And with more intensity comes the not only a greater possibility of successful engraftment, but also some of the side effects which we want to avoid in the short and long term. So striking this balance is a really important effort in making transplants safe for more patients. I'll focus on bone marrow harvest because that's the most common method of donation for thalassemia and sickle cell disease. And for those who are unfamiliar, a bone marrow harvest would involve the same donor who you can't really see here, but is in the prone position under anesthesia, who has a physician on each side procuring bone marrow through aspiration, typically about 100 times on each posterior iliac crest, until sufficient stem cell content has been collected to meet the needs of the donor based on, the recipient based on the recipient weight. But keeping in mind donor safety, and there is a limit to how much one can safely collect to make sure the donor remains safe throughout this process. And if I was to speak very broadly, the list of risks is much longer than this, and we certainly have very long conversations talking about risks and potential benefits. But if I was to simplify them, we worry about graft rejection, so the recipient having an immune-mediated rejection of the donor cells. And that can either be immediate or they can have a period of acceptance of these blood stem cells followed by rejection at a later time point. Transplant-related mortality, of course, we don't want to, in an effort to correct a chronic illness or prevent the ongoing manifestations of a chronic illness, have someone not survive the transplant, but this remains a risk that must be discussed, and that the causes of mortality would be most commonly infection and organ dysfunction, and commonly that's of the liver in patients with significant transfusion exposure, such as in thalassemia and iron burden from the disease, or graft versus host disease. And the absence of graft versus host disease and the universal availability of donors is part of what has driven the intense research effort into gene therapy. Infertility is also very important to patients and families. I've given a range here depending on the alkylating agent that is used, but infertility is quite, not guaranteed, but quite common in patients who undergo particularly myeloablative conditioning for transplantation. And then there's graft versus host disease, which I, despite several years of doing this, have great difficulty in conveying to patients and families, and we try to use educational tools, but really difficult to convey this risk, especially when sometimes families come to us so determined to pursue a curative option. The acute form of this complication can be severe and life-threatening, although we do have better agents to treat it, but can affect mostly the skin, the lower GI tract, and the liver. And these are patients who can come into transplant with liver injury to begin with. Chronic GVHD is often even more difficult to treat. It's chronic by definition, but also can take many years to get it to burn out, if it does at all, and can be mild or severe, but in the severe forms can be very debilitating, prevent people from working or going to school, significantly impact quality of life. And one of the manifestations we fear the most, although we fear all of them, is significant lung disease or fibrosis from chronic GVHD. So the last thing we want to do is to replace one chronic illness for another that could be more imminently life-threatening as well. So some key points about risk. Well, historically, matched sibling donor transplant has had a 20% higher thalassemia-free survival than outcomes with an alternative donor, although that story is changing. So bottom line is what donor options are available inform risk. Iron burden, and I'll speak a little more about the Pizarro classification, should be considered because this also historically, although to a lesser extent with newer approaches, has predicted risk or in some cases how the transplant is performed. And it's important to emphasize that younger patients do best, and there seems to be a clear signal that children under 7 years of age do best. But under 13 versus over 13 years of age is another time or age criterion that seems to come up consistently as predictive of greater or lesser risk, particularly with respect to graft versus host disease. And in our own institutional experience, I can attest to even patients who have done well in the end, who are older at the time of transplant, having much rockier post-transplant courses than some of our younger patients. It's not to say that adults cannot undergo transplant, and I'll speak to some adult literature, and I know we have several adult providers on the call today, but generally outcomes are best, and this is true for sickle cell as well, when performed at a younger age. So Pesaro is this beautiful town in Italy. This classification was developed to better have some sort of common language as with respect to risk related to iron burden. And so there are 3 criteria, one being the quality of chelation prior to transplant, and there are some specifics there because of course the devil's in the details a bit, who calls what degree of chelation good quality versus poor chelation, but there are definitions. Hepatomegaly, and then portal fibrosis on liver biopsy. And so the absence of any of these risk factors gives a score of 1, all 3 gives 3, and then 1 or 2 is a score of 2. I'll speak a little bit to modern outcomes with a matched sibling donor. So again, who the donor is matters, but typically more modern series would quote over 90% overall survival and over 80% thalassemia-free survival in most series. And a recent publication using registry data, so this would perhaps be more real world, although registries have their flaws as well, across Europe suggests even excess of 90% thalassemia-free survival with a matched sibling donor. Historically, busulfan has been one of the key components of the conditioning, and given this is not largely a transplant audience, I'm not going to get into all the nuances of transplant itself. I'm going to try not to get into all the different protocols, but just in terms of general principles, busulfan is an important drug in conditioning for thalassemia, although newer treosulfan, which is a sister drug of busulfan-based protocols, are becoming increasingly popular due to less toxicity. But with busulfan, part of the reason outcomes have improved is this drug is now given intravenously for several years now, and pharmacokinetics can be obtained to better target the drug. Too much, and we worry about complications such as sinusoidal obstructive syndrome. Too little, and we worry about graft rejection. And increasingly, protocols are using other drugs to replace more toxic agents. I referenced treosulfan and busulfan. And drugs like fludarabine and thiotepa are being used for thalassemia transplantation to replace cyclophosphamide. And there are some small series, some of which have had encouraging results, but again, the numbers are small using reduced intensity protocols. So somewhere in the middle of that spectrum that I showed earlier, with the hope that there is less toxicity and importantly, better fertility preservation, but this has yet to be really substantiated with data. So what about alternative donors? This is really anyone but a matched sibling donor, because most patients are not going to have a matched sibling donor. A full biological sibling has a 25% chance of being an HLA match, a fully matched HLA matched donor, and then you have to take out a quarter of those because there's also a 25% chance that a sibling would have the same disorder. So very few people have a matched sibling donor who is unaffected by thalassemia. Well, historically, thalassemia-free survival was about 20% lower with a matched unrelated donor, but really these data have changed, and I'm going to highlight one paper that has informed our practice in Calgary, really suggesting the results are now not quite the same, but approximating those of a matched sibling donor. Thiotepa is commonly being added to regimens, just like for matched sibling donors, to help prevent rejection, which is an even bigger concern when the donor is not a fully matched brother or sister. And I'll say that any mismatched unrelated donor transplantation, which is and has been done, Turkey has an experience that they've described, but clearly higher risks, more complications, particularly graft rejection and graft versus host disease, such that mismatched unrelated donor transplant and unrelated umbilical cord transplantation, these results really make these approaches experimental to date, according to most experts in the field. I mentioned I would highlight a protocol that's changed our practice, and this is the protocol I was referring to, using treosulfan as well as thiotepa and fludarabine, with or without ATG, depending on whether the donor is a matched sibling or not. But these interesting results from Italy with 60 patients, you can see most of them were children, but there was a small cohort of adults where they didn't actually see a difference in outcomes with adult patients compared to children. And this may be reflected by the fact that even within those age demographics, Pizarro risk group didn't impact outcome as well. And treosulfan is less hepatotoxic, so that's probably the key factor in these outcomes. And while rates of graft versus host disease were not zero, and really one would never quote or almost never quote such low rates of GVHD for an allogeneic transplant, these are pretty low rates of graft versus host disease for an allogeneic transplant, especially considering that 2/3 of these transplants were from unrelated donors. So what about haploidentical transplant, which has really transformed our ability to find donors for many conditions? So this is when a half-matched parent or even a half-matched sibling or aunt or uncle could be used as examples to mean that really 90% or more of patients would have a donor if this could be done safely for everyone. The Thai group in Bangkok has had very good results, which are summarized here with this approach using myeloablative busulfan, which I've described previously, and cyclophosphamide after transplantation to prevent graft versus host disease. And you can see rates of thalassemia-free survival are very high. Rates of severe graft versus host disease are, I would say, pretty acceptable from a transplanter's perspective for especially a half-matched transplant, although many patients did have graft versus host disease, as you can see on the final bullet point, but few of them had severe forms of GVHD. And I'd also highlight that they use an approach for pre-transplant that we have also adopted here in Calgary, using fludarabine and dexamethasone for several cycles, 5 days, once a month for a couple of months prior to transplant, which they've shown in separate publications, again, the same Thai group, to really help improve outcomes for patients with Pizarro class 3 disease. So we've, given it's relatively, that it's well tolerated, we have adopted this for all donor types at our institution. And so the success of this work in Thailand is likely going to inform North American clinical trials that are either just starting or in development to see if haploidentical transplantation can be offered more universally. So again, what about GVHD, one of our major risk factors? If I was to summarize the data I've presented in these more recent cohorts, severe acute GVHD is typically in the realm of 5 to 15%, and chronic somewhere in the 5 to 10% range, if I'm accounting for most of the studies that I've referenced so far, with that one Italian paper having only one patient in 53 who had more limited chronic graft versus host disease. But I definitely don't want to underestimate this risk when I speak to families. So if anything, I err on speaking to a higher percentage, not overestimating, but I definitely don't want to understate this risk. So I'll summarize now for thalassemia by reviewing the 2021 Thalassemia International Federation guidelines, which really align to our thinking at our institution. In that transplant should be offered, it doesn't mean families have to do this, but typing and a discussion about transplant, we believe should, as do these guidelines, be a consideration for those who have a fully matched donor in the family at an early age. Bone marrow or cord blood from the HLA identical siblings. This is not unrelated cord blood, but sometimes a donor sibling could be quite small, and there's established precedent for combining bone marrow and cord blood from the same HLA identical sibling. But these would be the most standard stem cell sources for transplant for thalassemia. Increasingly, institutions or organizations are endorsing matched unrelated transplant more routinely. So at our institution, we will offer a 10 out of 10 matched unrelated donor transplant to anyone with thalassemia. The NHS in the UK has recently amended their guidelines such that fully matched unrelated donor transplant is considered acceptable as well. Haploidentical transplant is typically still recommended in the context of a clinical trial. Myeloablative regimens are still considered standard of care to give the best chance of donor engraftment, although there are some studies, albeit with smaller numbers, using less intensive conditioning regimens. And this is a key point, not only for thalassemia, but for sickle cell disease, that the post-transplant care is not just about the transplant. It's about the transplant exposures and risks that come with transplantation and allogeneic transplantation, but also the thalassemia status and the medical status of the patient at the time of the transplant. So re-engaging our hemoglobinopathy colleagues is really critical in the post-transplant care for these patients, looking at iron burden, some of the issues which may have developed prior to transplant may not be expected to reverse post-transplant. So important to consider both the transplant exposure as well as the issues related to the hemoglobinopathy prior to transplant. And also worth emphasizing that transplant is generally considered cost-effective, including in low-income countries. There's some great work done by Cure to Children in collaboration with some lower-income countries where in, say, Sri Lanka, Pakistan, India, based on some modeling, a transplant's equivalent to 3 years of chronic transfusion in terms of cost. So and there are some centers of excellence in those countries. In fact, that can be a driving factor to pursue transplant in some of those settings because it actually is cost saving. I'll just speak a little bit to quality of life. This abstract from some of the expert colleagues in Italy have indicated for patients who engraft successfully and who are free of graft versus host disease, and those are two big qualifiers, of course, indicate that their quality of life after transplant is very similar to the general population, which is quite encouraging. Now, I have to emphasize that when you tease out the patients who have graft versus host disease, and of course, if they rejected, then they would be more aligned to someone who has ongoing thalassemia. But those who had successful engraftment and were free of graft versus host disease had comparatively better quality of life than those with best supportive care ongoing and comparable quality of life to those in the general population. So what else do we know about long-term effects? So this multi-center retrospective analysis encompassed 176 patients, and the period of study went back a couple of decades. So one has to think of that when considering some of these outcomes. Notably, a quarter had graft failure events, but and typically, as I mentioned, we wouldn't quote a 25% risk of graft failure nowadays, but the data are what they are. Of note to me, though, was that a quarter of these graft failure events occurred late, over 1 year post-transplant. But also importantly, that when transplant was performed at a younger age, end organ dysfunction was pretty uncommon. And it was also reassuring that late mortality and persistent chronic graft versus host disease, fortunately in this cohort, was relatively rare. So most patients were coming off immune suppression in the long run. So all put together, a decision to pursue transplant for thalassemia is impacted by resource availability, a donor being available. Now, haploidentical transplant may change that, as might, or I would say will, gene therapy. Of course, the values of the family and the preferences and recommendations of the care team are going to inform this decision and their ability to adhere to the recommended therapy. But that, of course, applies to best supportive care as well. And GVHD appropriately gets its own shout out in this diagram because it is a very important consideration when contemplating transplantation. So what about sickle cell disease? So sickle cell disease, changing gears, I would venture is more than a hemoglobinopathy. I really like what Salim Korbachioglu from Regensburg describes it as a systemic vasculopathy in all of his talks, not just a single amino acid switch such that we have hemoglobin that's more prone to polymerization, but really a multi-system disease that can affect really any organ in the body. And this audience will be very familiar as to the marked impact it can have on the quantity and quality of life. And so for younger patients, this could be manifest by hand-foot syndrome or acute chest syndrome, which has a case fatality rate of about 2% per episode. We always worry about stroke, although with TCD screening, that incidence has decreased, but is still present. But then as patients get older, we start to worry about different problems such as avascular necrosis, and right-sided heart failure, renal nephropathy. And so the life expectancy is still just under 50 years of age. And unfortunately, in some parts of the US, as an example, has not increased, but in fact has decreased, depending on the region in the country in which people live and their access to care. So the social aspect of medicine is very important, as we all know. The first transplant for sickle cell disease was in a patient with AML, and I'll speak more to myeloid malignancy a little further on, but proof of principle was demonstrated that the child was cured of both diseases after transplantation from a matched sibling donor who had sickle cell trait. And to fast forward, these data were from 1986 to 2013. They're already out of date given there's been a huge uptick in the number of transplants for sickle cell disease. So now CIBMTR is reporting over 2,000 recipients of transplantation internationally. Most of these are matched sibling donor transplants that have been performed in this cohort. These were all matched sibling donor transplants, and most had myeloablative conditioning. But I'll highlight while event-free survival and overall survival was generally in excess of 90%, if we look at perhaps a more accurate marker of success, that would be graft versus host disease free survival. So someone who is no longer sickling obviously has survived and is free of graft versus host disease. And the likelihood of achieving all those goals is not as high if someone is over 16 years of age at the time of transplant. Increasingly, there's data to suggest that threshold is perhaps more accurately defined at age 13. Reminding us of the spectrum of intensity of conditioning. And then stopping to think, well, what is our goal in transplantation? It might seem really obvious, but I've heard a colleague from Vanderbilt describe this quite well, that, if sickle cell disease is a hammer and the body is a wall, he says to patients and families that, that hammer's put a lot of dents in the wall, and we're not anticipating that those dents will be fixed, but we're hoping that we can stop adding more damage. But we definitely hope for survival. That goes without saying, but enough donor cell engraftment to prevent ongoing sickling crises. We definitely want to avoid graft versus host disease, and ideally to have no evidence of hemolysis. But you can have enough engraftment to prevent sickling crises, but still have evidence of hemolysis, and I'll get to that in a second. And we would ideally want to have minimal impact on quality of life, or certainly in the long run to improve it, but ideally even in the short term to not adversely impact quality of life. So other important goals, we want to minimize acute and long-term complications, again, from the transplant and from the sickle cell disease itself. And so the older a patient is when they come to transplant, they are likely to have a differing level of end organ dysfunction or tissue injury than someone who undergoes transplant at a younger age, and that's certainly borne out in terms of the rates of disease-free survival based on age. We typically advise, as I used that analogy a few minutes ago, that we don't think that organ function will improve, but we do have some preliminary data that maybe challenges that dogma. But realistically, I still counsel families not to expect reversal of existing damage for the most part. We'll speak later about treatment-related neoplasms, but this is an important area of research, and people are very appropriately paying a lot of attention to this risk, both with gene therapy and allogeneic transplant. And then fertility preservation, again, a high priority for patients and families. So ideally, you'd think less intensive conditioning would be a way to achieve these goals. But I'll speak to the American Society of Hematology guidelines in a moment, and where we are with data to substantiate what type of conditioning one might consider. I said a few minutes ago that I'd speak to degrees of chimerism. So there are several several landmark papers that have suggested that even 20 to 25% donor engraftment, so donor blood cell engraftment, is sufficient to prevent sickling crises. But in this large French cohort, and the French have really been leading the way in terms of transplant for sickle cell disease and our understanding of long-term outcomes for some time. Having between 25 and 50% donor chimerism can be curative from a sickling crisis point of view, but we can still see evidence of hemolysis in some patients, and we have some individuals in our program who are in this category. I referenced the American Society of Hematology guidelines. So for children, for reasons I will explain, myeloablative transplant is still considered the gold standard over less intensive approaches. And for adults, because treatment-related mortality has been so much higher for adults with sickle cell disease with myeloablation, reduced intensity, or in particular non-myeloablative conditioning, the least intensive regimens are preferred for adults. And some multi-center international clinical trials have had to stop due to excess toxicity with myeloablation. So the French have really set the bar for outcomes with myeloablative transplants. And you can see here 98% survival, 95% disease-free survival with busulfan. So that's cure and cure without sickling crises. It doesn't speak to late effects, but it sets a high bar for engraftment and survival. But despite these data in North America, reduced intensity conditioning or non-myeloablative conditioning is increasingly being used. And this STAR survey shows, if you look at the MAC there, that's the myeloablative conditioning, is being used less commonly in North American transplant programs than projected to. And now this projection is in the past, but the projection was that would be even used less commonly. So less intensive conditioning regimens, despite those excellent outcomes in France, is more common in North America. So why might this be? The ASH guidelines published are based on those outstanding data in France. Well, the highest published event-free survival is with myeloablative conditioning. The less intensive conditioning options might be close, but they are not as high as that 95% mark. There are larger numbers in the French experience, and as I mentioned, the lowest rates of graft failure. Reasons why North American programs are increasingly using less intensive options is the hope that fertility might be better preserved, but we don't have data to substantiate this hope, even though we certainly will be very happy if it pans out that fertility preservation is better, but we don't have the data to show that patients post, sorry, you can hear a fire drill in the background in my institution. I'll keep going. Rates of graft versus host disease are similar with melphalan and fludarabine-based reduced intensity conditioning, but if one was to use the National Institutes of Health regimen, are essentially non-existent. And there's less decline in health-related quality of life early post-transplant. So if we can avoid that decrease in health-related quality of life early post-transplant, then that would be desirable. Further to that, I'll just highlight a multi-institutional North American study that we are a part of using this NIH regimen in children and young adults. These outcomes are comparable to those in older patients published by the NIH with 100% survival. The graft rejection rate is comparable to that seen in adults. But notably, and we need to do better here, 25% had what we call poor engraftment, where they either had graft rejection, need for a stem cell boost, or myeloid chimerism less than 50%. And so with the next iteration of this study, we're hoping to tackle these issues by using subcutaneous alemtuzumab. There's data out of Chicago to suggest GCSF post-transplant can enhance engraftment, and the data from St. Louis and collaborating institutions to confirm that it's safe to give GCSF post-transplant. And you can also see one of the other key objectives of the study was to see the impact on health-related quality of life, and we were happy to see that health-related quality of life didn't diminish even as early as day 30 post-transplant. But this regimen needs fine-tuning due to the engraftment issues that I've highlighted. With respect to unrelated donor transplant, the ASH recommendations are still that this be performed in the context of a clinical trial, and I'll explain this. So this highly anticipated BMT Clinical Trials Network study was an important addition to our understanding of unrelated donor transplant, but was very disappointing in terms of its outcomes. You can see while graft rejection rates were generally acceptable, the rates of particularly chronic graft versus host disease were unacceptably high. So instead of giving up on this approach, what could be done? Well, abatacept has been used in 2 different consortia to tackle this problem. This is a CTLA-4 blocking molecule that comes out of the rheumatology literature for rheumatoid arthritis. It is now the only FDA-approved medicine to prevent graft versus host disease and is being studied across the spectrum of pediatric transplantation. But within the STAR consortium, a 24-patient study or cohort that has been presented in abstract form, this publication should be forthcoming soon, has shown really encouraging results with the addition of this medication, particularly when 8 doses are used. So this cohort needs to be expanded upon to further validate these results, but this could really change the story about unrelated donor transplant for sickle cell disease. But it doesn't solve the problem of donor access because finding fully matched unrelated donors is still very difficult for people of African background. So we still need more options, again, where gene therapy will hopefully play an important role, but also haploidentical transplant, where, as I mentioned, almost everyone has a donor. And the 2 main challenges that I mentioned previously are graft rejection and GVHD with haploidentical transplant. We haven't solved the graft rejection issue particularly in children. I'll reference the consortium led by Vanderbilt, where 80 patients were presented at ASH this past December in New Orleans. But all their graft rejection events were in patients under 18. So 75% of patients under 18 had successful engraftment, but in contrast to all the adults. So there's something about graft rejection and perhaps residual thymus or host immunity that needs to be figured out in pediatric patients. And then GVHD, so the 2 main ways we can tackle this or have tackled it to date with haploidentical transplant is using post-transplant cyclophosphamide or manipulating the graft. So after the donation has been made, but before it is infused, removing the contents of the graft that are more likely to cause graft versus host disease. And so this, the data are emerging and evolving. Most people recommend still doing transplants, the haploidentical transplants in a clinical trial, but there are enough data out there that some institutions will consider transplant using a haploidentical donor on a case-by-case basis, particularly for severe disease. I referenced this Vanderbilt-led consortium, and again, 80 patients, many of whom were adults with excellent outcomes, and the pediatric patients having more graft failure events. And we will be participating in this German and European-led study using that graft manipulation technique that I mentioned to try to improve engraftment and reduce risk of graft versus host disease, as well as using less gonadotoxic chemotherapy to hopefully have better fertility outcomes for these patients. But these are studies in progress. But cure is more than survival and engraftment, and there is much that remains to be learned. Despite thousands of patients having been transplanted for sickle cell disease, we still know less than we should about long-term outcomes. This STAR and some of this being institutional data from our place suggests that myeloablative conditioning, not surprisingly, is a risk factor for organ dysfunction post-transplant. But we have a signal that renal and respiratory function can stabilize post-transplant, even signal in small numbers of patients, so I don't want to overstate benefit that there could be some slight improvement. And this, notably for restrictive lung disease, is a situation where we'd expect annual decline in forced vital capacity every year in these patients. Looking at neurologic outcomes, the STAR registry has over 200 patients where neuroimaging and neurovascular disease were reviewed, and stability was really the main finding, with a small number having progression in their neurovascular disease post-transplant. And we want to address this issue of not having enough of an understanding to know what end organ function and quality of life is long-term, and most importantly, to be able to guide patients and families in decision making. So this prospective registry study, which will have biobanking and neuroimaging correlates, aims to address this knowledge gap, looking at best supportive care, transplant. Hopefully there'll be some ability to compare gene therapy, and focusing on neuro outcomes, health-related quality of life, and pain. So if I was to summarize these transplant outcomes for sickle cell disease, with particularly myeloablative approaches and some reduced intensity regimens, we would quote a 90 to 95% disease-free survival. There is still a risk of acute and chronic GVHD. The NIH regimen has almost no GVHD associated with it, but more issues with engraftment. A matched sibling donor is increasingly being offered around North America. Matched unrelated donor outcomes are improving, but there still remains more opportunity to improve outcomes, particularly with respect to chronic graft versus host disease, and generally performed under a clinical trial. Although there are some institutions, just like with haploidentical transplant, for very severe phenotypes, weighing what is known against the risks of that patient's phenotype and concern about their ability to survive well into adulthood. And then haploidentical transplant, high rates of disease-free survival for adults, not quite as high for children, although these events are not fatalities. These are graft rejection events typically. The rates of severe acute or chronic GVHD are in the range of 5 to 10%. And ongoing efforts to tweak this protocol, the Vanderbilt group mentioned mandating hydroxyurea, although most patients ideally would be on hydroxy anyway, and perhaps using simple transfusions instead of exchange transfusions pre-transplant as efforts to suppress marrow proliferation and promote engraftment. And then a few comments on genotoxicity. So this publication came out just this year in JCO. Clonal hematopoiesis in sickle cell is an area of increasing study. I mentioned the first patient transplanted had AML. Increasingly, we're learning that patients with sickle cell disease do have a higher risk of myeloid malignancy, but that I don't want to overstate that. The absolute risk still remains quite low. And then increasing population-based studies of patients with sickle cell disease are identifying clonal hematopoiesis, particularly in adults with sickle cell disease. In speaking to colleagues, the signal seems to be in those under 20, the number of patients with clonal hematopoiesis seems to be quite low. The NIH has described in several of their adult patients with graft failure who've developed myeloid malignancy TP53 mutations, and in some of these patients, these were identified retrospectively on baseline bone marrows prior to transplant. This data set also highlights that in the pediatric cohort within this CIBMTR registry data, busulfan was the cause of malignancy in several patients. So we still have to better understand how busulfan confers risk. The gene therapy, one gene therapy study was closed for a time because of busulfan-induced myeloid malignancy. So important to consider busulfan, the role of low-dose total body irradiation when that is used, and where age, the relative importance of age compared to exposures. So much has to be learned here. And then factoring into all these decisions is the growing repertoire of disease-modifying agents. So the risk-benefit ratio for all these options is evolving. Transplant practices are changing. Best supportive care is evolving. Gene therapy is here. So what can be accessed, the relative safety of each, and the comparative benefits are constantly changing. And so I won't speak more to gene therapy, just to highlight that in Canada, we're going to have to decide who gets access, or provinces will have to decide who's going to access this therapy, and gene therapy for sickle cell disease is on the horizon for sure. So I hope I can say that we covered our objectives. I'm just looking at the time, wanting to give a couple minutes for questions. And I'd like to thank you for your attention and for joining today.
Thank you so much, Greg. That was an excellent overview, and really appreciated the review of the literature so far. If anybody has questions, you can feel free to put them in the chat and I can ask them, or if you'd like to unmute yourself, please just raise your hand and I can call on you. There's one comment in the chat here. Great talk, Greg. Yes, it was.
Thank you, David. Maybe I'll ask you a question. David, are you offering unrelated donor transplant routinely or alternative donor transplant routinely for thalassemia at McGill?
In a while, we have done it successfully. I wouldn't say it's routine, and I'm certainly for young patients, like very young or newly diagnosed, and the same, I guess, could be said for sickle cell. Is I would probably not even entertain the idea of transplant, because I really do think gene therapy, I think in 5 years' time will be we'll be having a different discussion, I hope, given the preliminary evidence. But I have for Thal, yes, I have done that in the past, but we don't do it routinely.
So there was a hand raised first and then a question in the chat. So I'll go to Lanny Lieberman, whose hand is raised.
Hi there, Greg. Thanks. I'm a pediatric hematologist in Toronto. So really great overview and nice review for those of us who haven't done transplant in a long time. Just a question for you, you emphasize the benefits of the younger patient, and I've had quite a few patients come to me asking for this, and similar to the comment here, I'm a little bit hesitant to send them off for a well patient who's young but on hydroxyurea, who's had very few complications, hesitant to even send them for the consult. So are you finding more consults? Are you tending to transplant only the ones that are sort of sicker, have more issues with crises, et cetera? Or what's your approach at your center?
Great question. I think it's fair to say, and I see some of our hematologists on the call. First of all, we have a very collaborative relationship, and not to say that you don't, but we're very grateful for that. But the demographic that we have in Alberta, we've had a huge uptick in our number of patients with sickle cell disease, mostly first-generation Canadians, who all of them seemingly want transplant, and my colleagues can correct me if I'm wrong, but pretty much everyone is requesting HLA typing, and if they have a matched sibling donor, requesting a transplant. And so we are willing, based on the existing data, to offer matched sibling donor transplant to anyone with a matched sibling donor. I find I spend part of the conversation trying to make sure they understand, for those who are first generation Canadians, that the natural history of sickle cell disease with best supportive care is not necessarily the death sentence they might think it is, based on where they come from and where access to care would have been different, and many having had family members who died suddenly of this disease. So trying to remind them that many, in fact, as you know better than I, most patients survive to adulthood. But I think our adult colleagues are often some of the greatest proponents of transplant, because they deal with the issues that inevitably set in adulthood. So short answer is that we offer to everyone. We tend to wait till they're 3 or 4 years of age, just for safety. We find that we can better identify signs and symptoms with the older toddlers compared to a younger patient. I don't know if I missed the first part of that question in my answer.
No, you did. It's just mostly about, how to manage the sickle cell patients that are requesting it when you think that their disease is very well controlled, so to speak,
Yeah, and sorry, I knew the real tough balance here is that there's clear data from EBMT to show that kids under 5 actually have the very best outcomes, lowest risk of mortality, and we know kids under 13 and even under 10 have lower rates of GVHD. So the transplant is definitely safer at a younger age, but then, for us to feel like it was the right thing to do, particularly if an adverse outcome was to result, living with those recommendations when someone has a mild phenotype is more difficult to justify. So it results in this difficult conversation. We're hoping with the registry that we've established that if we can more accurately define the potential benefit of neurocognitive protection as an example, because we expect kids with sickle cell disease to lose IQ points slowly over their lifetime if transplant is neuroprotective in that way, or if quality of life can be more clearly preserved, or end organ function, this will help us make these difficult decisions with families.
Thank you. It's great.
David?
So I'm going to have to compliment Nicola on that photograph. So given what you just said in terms of transplanting kids, the younger the better, but given the potential wider availability of gene therapy, where do you see gene therapy, say 5-10 years down the road, and would you offer transplant to the very young patient today?
Also a great question. At least in its current iteration, gene therapy involves myeloablative busulfan, so the fertility issues remain. I think with matched sibling donor transplant, it's going to be difficult to recommend, at least based on the data we have, gene therapy, in my opinion, over matched sibling donor transplant, but certainly an opportunity to replace alternative donor transplantation. That being said, some of the haplo results are really quite good. Also complicating this discussion is genotoxicity. So receiving busulfan exposure and then autologous cells, we're still learning and worrying about what the impact of alkylating agents or low dose radiation is on residual host hematopoietic cells. So that could also very much inform the discussion as well. Age is going to remain an important variable, not only in terms of successful outcomes as you've alluded to, but more information about risk of clonal hematopoiesis and age, I think, is going to guide that discussion too. So it's going to be an interesting, in some ways, a good problem for our patients and families to have. They've had so few options historically, but helping them navigate these various options and what to recommend. And then there's cost. I'd love to hear, is probably a whole discussion in and of itself, and we're going to be discussing this at the annual Cell Therapy Transplant Canada meeting. But is any province going to pay $2.8 million for a gene therapy product for a patient, and that doesn't include the rest of their the healthcare costs that go into gene therapy? So if yes, then that's going to be potentially a pretty big bill really quickly for provinces if the 7,000 plus people in Canada who have hemoglobinopathies all decide that they want to pursue that option.
Dr. Lieberman, is that okay? You put your hand down. There's some questions in the chat here, which I'll just read out. So the first one is, how are you dealing with the risk for infertility? Is fertility preservation and future assisted pregnancy / conception easily accessible or covered by the government?
So these are great questions, and in fact, I've found earlier in my career, when we were just starting to offer transplant, the conversation stopper with many families was fertility, not the risks of mortality or GVHD. I've had parents say with accuracy or state the risks of various sickle cell complications, including sudden death, but when we got to infertility, that was the deal breaker. And for some of those young people, and I'm proud to say with one example, this young woman was 12 when I first met her, and we decided to defer because she wasn't able to have an equal seat at the table, if you will, and her mother did not want to make that decision for her. And fortunately, years later, we had a different option. So I know our institution, like Sick Kids, and I know McGill and others have used the NIH regimen. Not everyone uses this regimen, but it involves low dose total body radiation and no chemotherapy. And there are reports, and we've had institutionally examples of successful pregnancies We still recommend sperm banking for boys that are old enough, and where it gets more complicated, as is indicated in this question, are the pre and post pubertal females. Post ovarian, oocyte egg cryopreservation is not covered in Alberta, unfortunately. So that's a $10,000 cost for our patients if they were to pursue egg cryopreservation. It also requires physiologically that the females be post-pubertal, but also typically have to be 15, 16, or 17 to realistically undergo a transvaginal ultrasound and percutaneous sampling. So physically, they could technically undergo this when they're post-menarchal, but psychologically and realistically, it's not feasible for younger adolescents. There's the cost, and then there's also the issue, although this has been safely done, and there's some great talks at ASH about this, giving the high-dose hormones required for egg stimulation, that can be a risk in some of our patients. And we had this discussion for a young woman recently where her stroke history was such that we did not recommend that approach. Ovarian tissue cryopreservation has been done for decades in France and for longer in the US, typically under research protocols, but we've been keeping our ear to the ground with our oncofertility colleagues to make sure we didn't miss the time when this was no longer considered experimental. And our colleagues, at least locally, feel that while they wouldn't call it necessarily standard of care, they no longer consider it experimental in Canada for ovarian tissue cryopreservation. So we have now had our first, and we will have 2 more patients undergo ovarian tissue cryopreservation with their central line placements. And that is being covered under hospital operational costs, and then an operating grant that our oncofertility colleague is kindly using to help support the storage, although she is hoping that families who can afford it will pay for some of the storage. So in the US, they use more direct language. They feel this is standard of care. I think in Canada, we're really embarking now on a time where there are more options, but fertility preservation is definitely a huge component of these discussions. I see a question about educational resources. We've developed some resources within the STAR consortium. We're always happy to share those. One resource I'd like to highlight is the National Marrow Donor Program. The NMDP has a Peer Connect program where trained volunteers, so it's not just any person who's had a transplant can tell their story. They have to be trained in having conversations with people who are considering transplant. But these are people who've undergone transplant specifically for sickle cell disease. So those connections can be made, and I've through our STAR conversations with the NMDP, I've received confirmation that they will allow for Canadians to participate in that program as well.
That's really interesting, Greg. Both points that you just made about offering ovarian cryopreservation and this resource. I can answer for the time being. We don't have anything on the CanHeme website, but I think maybe I should be in touch with you, Greg, to see if we can see what's available through STAR.
Yeah, we have an education and advocacy committee within STAR that I'd be happy to connect you with, because so much time was put into these resources with the goal of helping patients and families. It would be a shame not to maximize their potential benefits.
Yeah, that's wonderful. Thank you. I think I don't see any more questions in the chat. I don't think I see.
I just see one about an age cutoff in adults. So,
yes, sorry, yes.
So for thalassemia with the treosulfan-based protocols, the outcomes are looking quite encouraging for adults, but I would probably be more cautious there with now that gene therapy is available, of course, with the big question about whether or not that could be funded or not. In adults with sickle cell disease, certainly when I speak to Julie Cantor and other colleagues abroad, they really feel that gene therapy is likely going to play a much larger role in adults. But with the NIH regimen, there is actually now if someone has to match sibling donor, I'll qualify, so that's not that's the minority of patients, but the NIH protocol has been used even up to age 50, 60 with success. Haploidentical regimens are being offered quite routinely. At Hopkins, for example, they will offer a haplotransplant to almost everyone, provided they have a good informed consent discussion, which is integral to any of these conversations. I don't know if they have an upper age limit, but I know increasingly patients even up to 40 years of age are included in these clinical trials. In the STAR consortium, we have a very interesting and adolescent young adult protocol that we're very excited that's about to just got FDA approval, which we use post-transplant cyclophosphamide for sibling and unrelated donor transplants in combination with abatacept and no immune suppression thereafter, which is really desirable for any patient population, but especially in sickle cell disease where PRES, posterior reversible encephalopathy syndrome, is a big concern, renal issues related to those drugs. This is based on really encouraging data in adults with AML, where they've had in a population that has historically had very high rates of graft versus host disease, they're seeing very low rates of GVHD. So we're excited to be exploring this in sickle cell disease in an older demographic that is more prone to graft versus host disease and more prone to toxicity with immune suppression. And that's with a reduced intensity approach.
See a comment here, current state of gene therapy and barriers access would be a great next topic. Thank you. I will definitely take that feedback back to the education committee. I think with that, Greg, just another comment, excellent presentation, thank you. It really was, oh, here. Is there a similar approach to sickle cell disease /STAL by transplant teams across Canada?
Great question. We on the PED side, we have national calls, and this is my area of passion, so I'm really pushing for us to, and there is a spirit of collaboration. I won't say that there isn't, but us to really consider more options for these patients and families. But at our National Cell Therapy Transplant Canada meeting, there's already interest expressed, and this has actually been initiated by some of the adult transplanters at Princess Margaret to establish a working group where we can more readily share ideas. I think we have a good relationship with our adult colleagues here in Calgary and are increasingly chatting about patients, especially those who might be crossing the 18-year barrier or what has been a historic barrier, to make sure that they don't get lost in the shuffle with respect to curative options, but also making sure that we exchange knowledge and ideas. So we're hoping to expand that across Canada. So at the Halifax meeting this May, we're hoping to get that going. And I should also highlight for the STAR consortium, even though it's got transplant in the title, two really key components of the STAR consortium for me are the fact that we have a patient and family advisory committee that helps inform our research as well as our education advocacy agendas, not agendas, but our efforts. But also that non-transplant hematologists are very important members of our team to help us decide who is eligible, to make sure we are surveilling for the right potential complications and late effects after transplant. So really highlighting that collaborative approach. And, France has a model which I think really ought to be emulated, where they have it started out bumpy by their own admission, where they had a national forum for discussion of complex cases where they brought together hematologists and transplant physicians, and they found the learning was really exceptional bidirectionally, where hematologists were learning and becoming more current on more up-to-date and modern transplant approaches, and the transplanters were gaining more insight as to the hesitations of appropriate hesitations or caution, I should say, from their hematology colleagues, but also making sure they had a better understanding of sickle cell disease and the alternatives to transplant.
I think that that's it for questions. I just want to thank you again, Greg, on behalf of CanHeme. It was such an excellent presentation and a really interesting discussion to follow. Yes, this recording will be available on the CanHeme site. And with that, I'll thank everybody for attending. I'll thank everybody for their participation and wishing you all a good afternoon. Thank you so much.
Thank you again for having me and for joining today, everyone.